Okay, well, I'm very happy to be here. Thank you for joining this conference. And I understand the conference is about the non-memory aspects of dementia, looking through the lens of patients with Lewy body dementia. So I'm using this platform to talk about sleep. And I'm excited about thinking about sleep in the context of people with dementia, because I do think it's an area in which interventions can really make a difference. Sleep has many different components to it, and what I'm going to highlight today are different aspects of ways that sleep is dysregulated in Lewy body dementia, and maybe give you some guidance on whether you might need to have those evaluated, or interventions you might even be able to kind of implement at home to improve sleep in Lewy body dementia. So we'll just get started. And to start off, I also wanted to say that I'd be very happy to answer questions at the end, and hopefully we'll have a lot of chance to do that. So hopefully I won't even take all my time and we'll have more chance for questions. So Lewy body dementia has many different sleep problems. So it is a good dementia to highlight the breadth of sleep problems that patients in dementia can encounter and how these are sometimes treated. I will be reviewing the disorders and problems that are on this list on this slide. And we'll start with REM behavioral disorder, which is one of the hallmarks of many people with Lewy body dementia. It can be seen very frequently in that disorder, though not always. Then we'll talk about obstructive sleep apnea, which is extremely common in all older people, including people with dementia. And as such, we need to be aware of it because it can have a profound impact on disruption of sleep at night and also daytime sleepiness symptoms. It may also impact attention and cognition during the day. The third topic I will talk about is hypersomnia, or daytime sleepiness. And many people think that people with dementia who are excessively sleepy during the day, it must be because they aren't sleeping well at night. Well, if you have a loved one, or if you are a person with a Lewy body condition, you may notice that even if you sleep well at night, you may still feel, or that your loved one may still be very sleepy during the day. And in Lewy body dementia, interestingly, people can have a primary hypersomnia where their arousal systems just don't wake up during the day, and they need boosts for that. The fourth topic I'll touch upon are periodic limits of sleep, and this is related to restless leg syndrome. The periodic limits of sleep can be more common in people who have Parkinson's related conditions. And these types of limb movements are also seen in people who have restless leg syndrome. And they can cause arousals at night and sleep disruption. And there are fairly good ways of targeting those limb movements to help improve sleep quality. The fifth topic will be sleep fragmentation at night, including insomnia. This is a very large topic, but I think there's a way to approach disrupted sleep at night methodically. And I'll try to give you just an introduction to some principles about how to consolidate sleep at night, to get you thinking along those lines of what can be done for people with this problem. Finally, I'm just going to have a slide or two on fluctuations of arousal, which is also one of the hallmarks of Lewy body dementia, and we don't know exactly what causes that. So to start off with, we'll talk about REM behavioral disorder. REM behavioral disorder is one of the more interesting aspects of Lewy body dementia. It's one of the core features. So people with Lewy body dementia typically have some kind of problem with their thinking, more often attention and executive function or visual spatial things. That's a certain thing that you have to have. But then there are four other core features. One of them is this REM behavioral disorder that gives you a clue that someone may have Lewy body dementia. Now, not all patients with Lewy body dementia have REM behavior disorder, but it is very common. And I think I mentioned that. I'll show you some slides that demonstrate that. One of the interesting things about REM behavioral disorder is also there's one of the first symptoms that a person might have had in their life that even preceded their diagnosis of Lewy body dementia. It can actually come about 10 to 15 years before other symptoms of Lewy body dementia emerge. You can have REM behavior disorder and never get Lewy body dementia, so keep that in mind, but it can be a foreshadowing of the beginnings of a disease. Because it's such an early symptom in the condition, it can also be an early clue that you may want to get involved or consider being involved in early clinical trials that might be targeting Lewy body before you get the rest of the symptoms associated with the condition. So this is some slides which show these graphs, and I wanted to demonstrate the frequency or prevalence of REM behavior disorder in Lewy body dementia, and also when it appears in Lewy body dementia. So this is men and this is women over here. I hope you can see my cursor, but you can see on the left side is men and the right side is women. The line for REM behavior disorder is the red line, okay? And you'll notice when people are 50, this is age going around the bottom of the graph. At the very earliest age of 50 and going up to the very oldest ages of 90 and above. At the very earliest ages of 50, you see that REM behavior disorder is much outstripping any other symptoms that people have when they eventually get Lewy body dementia. So for many of these years, 50, 55, 60, 65, 70, you see REM behavior disorder as being one of the things that's most common in these patients who are eventually going to be diagnosed with Lewy body dementia. So maybe 15% of the people who eventually get Lewy body dementia already have REM behavior disorder at the age of 50, and then 20% at the 55, 30% at 60, 45% at 65, and at the age of 70, almost 60% of people have this condition, which also can be treated, so we'll talk about that. Now you'll notice this graph in women looks very different. There's an interesting story to that, and it may be that women don't express this disorder the same way men do, and they may actually have it, but it doesn't come to the attention of people because there's less active movement in dream sleep like you see with the men. Okay, let me go to the next. So you get the idea here that it starts very early and is one of the earliest signs, but it's more manifest in men than women, at least in clinical visits and what people complain about. Okay, so what is REM behavior disorder? I probably should have put this slide up first in case you didn't know. But REM sleep is the part of sleep where people dream. It happens in the last part of the night. And what happens in REM sleep behavior disorder, which I mentioned is common in Lewy body dementia and happens early on and can precede all the other symptoms, is that people actually act out their dreams while they're dreaming. Normally in dream sleep, which is a protective mechanism, we do not move, we're paralyzed. And you may have that experience of having dreams where you feel like you can't move. That's partly a sort of perception that you actually are paralyzed during REM sleep. And this is protective because you wouldn't want to be jumping and flying and running around during your sleep. So this is a normal mechanism that we're paralyzed. What happens in REM behavior disorder is that people, paralysis during REM sleep is lost and they actually can move and act out their dreams. You might have seen these videos of dogs sleeping where they're running and you can see their legs moving. Suddenly you know that they're dreaming about running because their legs move. Well, what happens with people with REM behavior disorder is they start acting out what they're dreaming. What's interesting is that their dream content tends to be a little bit more antagonistic. So people are typically acting out dreams where they're fighting or something bad is happening. They're being chased or attacked. So they're fighting back. The dreams feel vivid and they feel real and they start to fight back and swing and punch. And so their bed partners can actually get injured. And it can be a very a big problem with safety. When these events happen, people actually wake up, usually after about 30 seconds or a minute. And when they wake up, they open their eyes and they realize that they were dreaming. They remember that they were dreaming. At least if you ask them at that time, they'll say, oh yes, I was just dreaming. This is very different than sleepwalking, which happens in the early part of the night when people get out of bed and they have their eyes open and they're walking around, but they're not quite awake. In this condition, it's just lasting a minute with the flurry of activity while people haven't realized they're not in a dream and their eyes are still closed. When they open their eyes, they realize, oh, here I am in my bedroom. Whereas people are sleepwalking, they're walking around with their eyes open, but not aware of what's going on. That's how it's different. As I mentioned, people can hurt people around them. And so safety measures are really important. People have broken their hands, choked or beaten their bed partners. And it's a serious problem, or they can actually just jump out of bed and land on their face and injure themselves. Let me go ahead and go to the next slide. This is a bit more sciencey oriented, but the idea here is just that the brain has mechanisms for controlling dream sleep in the pons, which is in the brainstem or in the deep part of the brain. And it's interesting in REM behavior, in Lewy body dementia, that's the first location where the synuclein abnormal Lewy bodies can start to collect. And so that's why you see it early on in the disease, and then they spread upward over time, over the course of years, but it can attack this area in the pons, which is important for the paralysis and dream sleep, and that's why you see it early on. I also wanted to mention that this condition of REM behavior disorder happens also in other disorders with these synuclein problems and that are Parkinson's related diseases. When those Parkinson's related diseases have synucleins that go to this pons region. And I listed 3 different basic conditions. You'll see Parkinson's disease here, very common. You all know about Parkinson's disease. Well, they can have REM behavior disorder too. There's Lewy body dementia, very common in Lewy body dementia to have REM behavior disorder. There's also another condition called multisystem atrophy, where synucleins coalesce in this base part of the brain, and they are very commonly have REM behavior disorder too. So it's not just Lewy body dementia, but it's a very core feature of Lewy body dementia. Okay, this is something that comes up in my clinic when I see people with this condition of REM behavior disorder when they don't have a full diagnosis of Lewy body dementia. And see, you can start off and just have REM behavior disorder, and you may not ever get Lewy body dementia. And there's different studies that say different things. And I'm just showing you this because I want to show you that some people think you have a 50% risk over 15 years to get Lewy body dementia if you have REM behavior disorder. But in other studies, they think it goes almost to 95% over 15 years. It's a wide spectrum. And it depends what age you are when you come in the door, because you can have REM behavior disorder even as a child in certain conditions like narcolepsy. So it's not always associated with this disorder. If you have something affecting the pons or the sleep mechanisms, you can get REM behavior disorder for different reasons. If someone has REM behavior disorder at the age of 50, they have a 5-year risk of developing a neurodegenerative disease that I've listed there of 20%, a 10-year risk of 40%, and 12-year risk of 52%. That's the lower estimates. But some series, like I just showed you, say 90% of people might develop this neurodegenerative disease. And as I mentioned before, REM behavior disorder is more often diagnosed in men. Okay, well, say we talk to somebody and they have this story that yes, the wife will or might say, oh yes, he punches in the air and then he wakes up and he realized he was dreaming. Well, is that REM behavior disorder or not? We have to understand that REM behavior disorder is really referring to the condition where that pons is affected by the synucleins. It turns out that you actually can have sleep apnea that can cause you to wake up from your dreams and act exactly the same way. So we can't know if this is REM behavior disorder or if it's just dream reenactment caused by sleep apnea that's causing you to kind of have an arousal in REM sleep. And so that's really important to know, because if you see somebody with REM behavior disorder, even if you have Lewy body dementia, I mean, it could be that it's from the Lewy body dementia, but sleep apnea can actually be promoting it and furthering it. And I have patients I see with Lewy body dementia at various stages, and we always check to make sure sleep apnea is also not a trigger. It can be an independent trigger, independent of Lewy body, but also can happen in Lewy body that sleep apnea is promoting it. And a third of patients with Lewy body also have sleep apnea, and sleep apnea can be treated as well. And it's important to treat that, or your REM behavior disorder might not completely get treated. I should also mention that some medications can promote active movement in REM sleep because they tend to block that paralysis. These aren't medicines that have to not be taken, but you have to be careful about taking them at night if you're having this condition. So I very much like serotonin reuptake inhibitors for depression, but if you're having a lot of REM behavior disorder, you definitely want to take these in the morning. Tricyclic antidepressants can cause this. A lot of antidepressants can actually promote REM behavior disorder, but they usually don't cause it. It's usually there's something else like predisposing people to have it, like apnea or narcolepsy or REM behavior disorder. And then you have to be careful to move these medicines out of the picture or to earlier parts of the day so you don't promote it. And that's a good treatment for REM behavior disorder. So how do you address REM behavior disorder? Okay, you first of all want to make sure that people are safe. So this means you want to tell people to remove sharp objects around the bed, bedside tables and lamps that they could, jump into. Weapons should be removed from the room, like knives or guns, because somebody might get a hold of that in a minute, when they briefly wake up and are confused. You can consider putting the mattress on the floor because people might jump out of bed and hurt themselves as they fall out of bed. While the condition is not under control, we recommend that the bed partner not share the same bed. People sometimes consider making a kind of jimmy-rigged sleep sleeve, like a sleeping bag, but a light sleeping bag, so that they can't start getting out and swinging their arms around. Sometimes I have a gentleman, when he goes to sleep in a hotel where he would then sleep with his wife, which he usually doesn't sleep with, he would make a sleeve with 2 sheets into like a little bag that he sleeps in so he doesn't jump out of bed. By the way, he also notices that if he eats M&Ms, which he used to like, that he will definitely have a lot of movement at night. So he then will sleep in his sleep bag if he ate some M&Ms that night. Okay, you want to remove aggravating factors. I introduced the M&M idea because you see chocolate is here. It really can be a very aggravating factor in some people. You might not think that, but hey, if you can get this condition under better control just by not eating chocolate at night, that's a big thing to easily be able to do without having to deal with other medications. Caffeine can aggravate this because caffeine causes arousals in sleep. So caffeine has effects on the body and sleep for 24 hours. So if you're really trying to chase this down by changing lifestyle, that would mean actually eliminating caffeine, including in the morning, including tea, including soda, including diet soda. So that's important. And people can usually transition to other things like non-caffeinated teas or non-caffeinated drinks and try not to reduce their quality of life and work off the caffeine in order to get better sleep. Alcohol also does worsen sleep apnea. It worsens sleep at night and insomnia, and it also worsens REM behavior disorder. So if you have this condition, this is something to also cut back on and hopefully be able to wean off on if possible. There are these medicines we talked about, like serotonin reuptake inhibitors, antidepressants, and things where you might want to remove them from the evening. Interestingly, mirtazapine is a favorite medicine, and it's not a bad medicine to help people with sleep at night for sure. But if somebody has these movement problems at night, it can make things worse, ironically. Again, Benadryl, that's the worst of things, can actually make a lot of movement things worse at night. And it was also mentioned in Dr. Bateman's talk that those anticholinergic medicines can also be bad for your cognition and thinking and potentially confusion. Okay, what else would we do to treat REM behavior disorder? Well, I already gave you the clue that apnea can cause REM behavior disorder, and it's very common in people who are over 60. Some people say 60% of people over 60 have apnea. So I feel, strongly that people should be considered for a sleep study. Any person who presents with REM behavior disorder condition, which is a very serious condition. The other thing that could promote movements at night are limb movements. And this sometimes can be something that actually persists into REM sleep where it usually doesn't because of the lack of paralysis, and can cause then arousals in REM sleep that also promote the events at night. Okay, what medicines do we use? I guess I've spent a lot of time telling you about what else you can do, because guess what? Those things are really important. It's not just about medicines. If you don't do those things, you'll have to chase this condition with more medication. and it might not be as effective. So we do all those things I just mentioned, treat the sleep apnea, remove the caffeine, the chocolate, the alcohol, and change the medications around that could be aggravating this condition. And then we consider melatonin as first line. Melatonin is used for a lot of different things in sleep, but one of them is REM behavior disorder, very specifically. And it is effective. The mechanism is not known for how it's helpful. And I typically start with 1 to 3 milligrams. People in the literature will use up to 12 milligrams. And I don't think this should be used wantonly without thinking about dose, because at higher doses, it can cause headache and diarrhea. And it has been reported to cause some negative mood in very rare cases, but you do have these cases. So I typically start from 1 to 3. Sometimes you have to go up to 6. You dose that at night before bedtime. There's also clonazepam that's used very heavily in the movement disorder clinics. I try to avoid clonazepam because of its effects on cognition and confusion and its addictiveness. And again, it's one of those medicines that's not typically desirable in people with any kind of dementia. And I think if we can get by with taking care of these people by using all those other things I mentioned in melatonin, we're much more ahead of the game. I think if you do those, typically you don't need clonazepam. Rarely and occasionally, you would do all those things plus the melatonin, do just a tad of clonazepam if it's really out of control. But again, I save that for the very last measure. The person would have had to have a sleep study, been treated for their sleep apnea. Maybe it could be used in an interval before all the factors have been addressed that promote it. But that's my general practice. Okay, so I kind of gave you an idea of REM behavior disorder, which is the core dysregulation of sleep that people think about in Lewy body dementia. But there are other things to consider because we want to improve sleep in these patients. And I'm going to highlight sleep apnea because I was just advocating to get sleep studies in these patients because it's so common in people over 60. 60% again of people over 60 have sleep apnea. So how would we know to screen for sleep apnea in a patient with Lewy body dementia? Well, if they have REM behavior disorder, that would be a reason to get a sleep study. If they have disrupted sleep at night, that would be a reason to get a sleep study. This is a screening tool that's often used for sleep apnea. It has questions like, do you snore loudly? Do you feel tired or sleepy during the day? Has someone observed you stopping breathing, or do you have high blood pressure? But there's also 4 other questions that are added. And one of those is age over 50, male gender, and a BMI, a body mass index over 35. So if you're a little overweight, if you only have 3 of these 8 things, you are at high risk for having sleep apnea, high risk. So just keep that in mind. You have a 5-fold increased risk if you just have 3 of those being positive. Well, most people with dementia are over 50, half of them are male, probably half of them have a BMI over 35. Many of them feel sleepy during the day. So basically you kind of meet all these criteria pretty much coming out the door if you are presenting with any dementia. So it's worth considering very low threshold for getting a sleep study. If somebody has Lewy body dementia and they have any kind of sleep complaint, sleepiness, or it's sleep disruption, they should be considered for a sleep study, and especially if they have dream reenactment. Other symptoms associated with sleep apnea are urinary frequency. Well, guess what? A lot of our people have problems with infrequent urination. If you get treated for sleep apnea, that can be reduced majorly. So that's important. Morning headache tendencies, restless sleep, and night sweats are also seen in sleep apnea. A hypersomnia, being sleepy during the next day, can happen in sleep apnea. Of course, that's common in Lewy body dementia, but it may be promoted by sleep apnea. As I mentioned, dream reenactment can be a sign of sleep apnea, and sleep fragmentation, which is common in Lewy body dementia, can be a sign of sleep apnea. What is sleep apnea? Okay, this is somebody's mouth over here in the top corner, and it's a genetic thing. You don't even have to be overweight, but the back of the airway, where the tongue is located relative to the back of the airway, can be so it sort of gets blocked when your body's relaxed, and this causes a little when you're sleeping, so the airflow is not perfect. This is not an ideal situation. There's no animals in the animal kingdom except for beagles, I think, that have this problem where they don't breathe well when they sleep. Obviously, it's not an evolutionary advantage, to be not breathing well while you're sleeping, because you're not aware of it and your body is not getting enough oxygen, it's being disrupted. But the idea or the thought is that because we have our vocal cords and have to speak, and we evolved for these abilities to use our larynx in very sophisticated ways, a bad side effect was the fact that this got a little bit more complicated and lent itself to having this problem with collapsing during sleep to a certain degree. So apnea is rated in terms of how many of these events you have during 1 hour. 5 to 15 per hour is considered mild, and 15 to 30 moderate, 30 or greater severe. But these numbers are sort of confusing, because somebody could have just 5 or 6 per hour, but have very severe oxygen desaturations, or they might have 30 per hour when they get to REM sleep, but just have an overall of 6. So don't be fooled if it comes out as a low number that it's not worth treating. These can be very important to treat. There's a lot of qualitative issues related to sleep apnea that don't relate just to the numbers. And here's an example. I put this big picture here just to kind of give you a figure feeling for what this is like. These little colors all along the top are different sleep stages. And in sleep, you see this red part, that's a REM for red, or red for REM. And the pink part here in the beginning is deep sleep. You usually have more deep sleep in the beginning, and then a little more periods of REM sleep at the end of the night. And that's why you have the REM behavior disorder at the end of the night. What you see here is this is somebody who in the beginning of the night was not treated for their sleep apnea. All of these little tiny ticks that you probably can't see are respiratory events. He had an average of 67 respiratory events per hour. That's a lot. And the oxygen saturation is going up and down. It's not good for your body. It's not good for your kidneys. It's not good for your brain. It's not good for your heart. As the oxygen and your blood vessels, oxygen going up and down. The heart rate is going up and down. Not good for your heart. When he gets started on CPAP, which is anyway this like a little nose thing that people can, it's one treatment. He has this huge long REM period because he's saved up all his hunger for REM over so many nights of not being able to sleep, that he has this incredibly extended REM period. And guess what? He wakes up feeling wide awake and he slept much better than usual. And his oxygen is all stable for the rest of the night. These are physiologically, very obvious problems that you would want to treat. So we don't want to miss sleep apnea. Well, what do we do with our treatment? A lot of people who have dementia or taking care of people with dementia think, well, they're never going to want a mask on their face. Well, that may be true. Some people can get used to it. Some people will never sleep without it because they notice that their cognition is so changed. I'll have someone who has had a very severe executive dysfunction. He drove all the way to Wilmington for a beach trip from Chapel Hill, and he forgot his CPAP mask, and he knows he can't think very well the next day, so he drove all the way back to get it, and spent 6 hours in the car just so he wouldn't miss his mask. He also does a lot of protests at the the legislature, and got arrested, and he gets worried that he's going to not have a CPAP mask if he gets taken to jail overnight. So it can be very important for some people. Side therapy, that's huge. Some people just have apnea on their back. Well, it's so easy to have people sleep on your side, but you might want to know that you have severe apnea on your back and your oxygen's, dropping during the night, and you need to sleep on your side. Some people are helped by raising the head of the bed. There are also dental appliances that help open the airway that people can get fitted. Treatment of nasal congestions can have a huge impact on sleep apnea, and that's one of the first line things we do when people are younger. Now, oral surgery I don't recommend in older people, especially when they have dementia, but it is used in selected cases when people are younger. Do not jump to surgery though in this population. By the way, with CPAP, I want you to be knowing that the first period of adjusting to a mask can be challenging because everybody's face is a different size, and a mask is going to only fit if it fits the right face. So you have to go through the right face, or if you're a mouth breather, it's much better to have one that goes over the mouth and the nose because you feel more comfortable. If you have a nose one and you're breathing out your mouth, it's very uncomfortable not to have the same air coming in. So there's a lot of tricks to get used to it and give it some time. The machines now are so quiet. They're so common when you go on the airplanes these days. They'll say, take out your CPAP machines, as they say, take out your laptops, because people are carrying their CPAP machines in their carry-on luggage. Okay, I know we're going to have to move a little more quickly, but I do want to mention some highlights in the next 4 sections. I wanted to make sure we cover the REM behavior disorder and that Lewy body, and the sleep apnea well. But hypersomnia, I have a couple slides on, and this is really important because sleepiness and Lewy body dementia and the Parkinson's related dementia can be completely a separate process from the REM behavior disorder or disrupted sleep at night. There can be a primary problem with staying awake during the day. So even if you have somebody sleep really well at night, they're still got this hypersomnia, because it's not about the sleep at night. It's about not being able to wake up during the day. And this has to do with changes in the neurotransmitters that support arousal.
Dr. Roth,
yes.
I'm so sorry to interrupt you. We can see your appointment reminder on there. I don't know if you can click out of that.
Let me stop. Let me see if I can go to a different, let me do a different, let's see.
If you want to take it off sharing for a minute, maybe. And
sure, stop share. Oh, look, a noon lecture. Unfortunately, it's not me. I wonder, you're probably getting a lot of my email reminders, a little embarrassing, but
No, we're not, just that one, but it was in the way of the screen. So okay. If you want to try and share again now, maybe we won't see that.
And, do stop me at any time and let me know. I appreciate that. Thank you, Lisa. So with the hypersomnia, I just think this is a huge quality of life thing. That's why I'm mentioning it, because it does need to be treated in a slightly different way. First of all, if people have hypersomnia, they have a tendency to be sleepy, and you absolutely want to remove medicines that actually further that tendency. Don't be giving people hypnotics, or taking hypnotics, or muscle relaxants are kind of the worst offender in my book, like baclofen and things like that, or Benadryl. Avoiding these things is going to be better for people because they worsen sleepiness. You need to treat these things in different ways, so you don't have to use these medications. Hypersomnia can also be caused by all the sleep disruption we talked about, the apnea, the REM behavior disorder, so you need to treat that as well. But I do consider modafinil, and there was a trial done, but there haven't been a lot of trials. So the unfortunate thing, modafinil is something that helps with alertness during the day. It's not quite a stimulant that affects cognition, but it helps with alertness. And it's very hard to get approved by insurance. I know Dr. Bateman was talking about the challenges with some of the new antipsychotics, but there's a really great workaround for this. And that is that you can look up on GoodRx, which I know Dr. Bateman mentioned, which is online, goodrx.com, and it'll tell you which pharmacies will provide this medication for much less. This is a great lesson in the craziness of a prescription medication cost, because you can look this up, and at some pharmacies, it costs $600 per month out of pocket. Some pharmacies, it's $400, and some it's $20. So it is absolutely mind-boggling. But you look it up, and it costs $300 at Harris Teeter, but it costs $20 at Costco, or it costs $20 at Walmart, and I don't remember, or $20 at CVS. And you can look there, and you can find which one it costs much less on. And if you find that it works for your loved one or yourself, some people feel like it's a lifesaver, that it brought their quality of life of their loved one back to normal. So this is something not to be forgotten. Modafinil is a stimulant, so you have to make sure that it's okay from the cardiac standpoint, but it's not quite as strong a stimulant as other stimulants are. Okay, I did just want to throw that in there because I didn't want to leave you not knowing about that or asking about that. Periodic limb movements of sleep and restless leg syndrome happen in a lot of older people. They also happen in Lewy body dementia. These are things that happen like on a clock-like regularity. It's not that you're just moving around a lot at night. It's like your foot moves like a little bit like this every 30 seconds. That's it. That's what periodic limb movements are. Or someone else might have a little bit of a whole leg moving every 30 seconds. It can get a little bit more dramatic. It might be bigger. But anyway, they're always the same, and they're always at a regular interval. Some people with limb movements, which are very, very common in Parkinson's related disorders, also have restless leg syndrome, which is not the same thing. So if you get a sleep study as limb movements, does not mean you have restless leg syndrome. But 20% of people have restless leg syndrome who have limb movements. But if you have, anyway, I won't get into the details. But anyway, restless legs is something you have when you're awake that bothers you. And it's worse in the evening. It's worse when you're lying down. It's an uncomfortable feeling. And it gets better when you move. They are sort of related because people with restless leg syndrome typically have limb movements like this, but you can have the limb movements causing disruption without the restless leg syndrome. Okay. What can you do about this restless motor clock thing that's happening in your body? Caffeine. Take caffeine out. It's really any kind of sleep related problem and movement related problem really does you a disservice here. Alcohol makes it much worse. Chocolate, we talked about that before. Exercise in the daytime, stretching out those muscles can also help get those muscles a little more relaxed. Exercise, that would be, is good for your dementia in general, 25 to 30 minutes aerobic exercise. Some medicines worsen PLMs and RLS at night, so we can take those out of the picture. I could give you lots of anecdotes, but I had a very, very healthy gentleman who had problems with his sleep, and he did everything right. He did meditation, he walked all day, he lived on the beach with horses, and he's living a very nice life. And all he ate were vegetable protein drinks so that he was very, very healthy, but he was taking Benadryl at night because that was an over-the-counter sleep aid. Just the opposite of what you want to do in this condition. Benadryl is like the thing that makes this super aggravating and much, much worse. So it's like the test you do to torture people who have restless leg syndrome. So that's something you'd want to avoid. Antidepressants at night, like I've talked about, can also worsen it. And iron, you can check your iron levels, and that can be something that can be boosted and make this work better. We use magnesium sometimes at night, add iron. And if we're going to use pharmacotherapy, because we've done all the other things, we've treated people's sleep apnea, we've treated people's REM behavior disorder, we've gotten rid of the caffeine, the alcohol. We sometimes use gabapentinoid compounds as opposed to dopaminergic agents because I think they have less side effects. And they've been as effective as those dopaminergic agents in a study of 7,000 people in a meta-analysis. We can typically use a very low dose gabapentin or very low dose pregabalin only dosed in the evenings before bed. But again, using melatonin may be beneficial and all those other things that I talked about. We're very close to the end of this talk now, so I think we're doing good for time. This last section I've added on because it's a little bit of an introduction to how we treat sleep fragmentation and insomnia. People who wake up in the night and can't fall back to sleep. It's a very, I find it a very satisfying thing to try to treat after you treat all those other things. But it takes a little time to fully understand. I give a community talk on this, and I've had people after the community talk come to me and find that this has been very helpful to them, and they sort of fix their own insomnia. Even people with Parkinson's related disorders. I have a gentleman who was sleeping much better after doing this, and also it can sometimes help with the daytime sleepiness. So let's get a little bit of an exposure to how to treat sleep fragmentation or do things that will help your sleep fragmentation. Well, first of all, you treat the things that we already talked about, the REM behavior disorder, the apnea, the RLS, the PLMs. You take out caffeine, and absolutely, you don't want caffeine if you're having sleep problems. You address sleep disruptors, which I didn't identify in a list, but reflux is one of them. Nasal congestion, which we use nasal steroids for. Pain, which we do not use opiates for, but use Tylenol, arthritis, nocturia. For the reflux and the nocturia and the circadian rhythm, I typically recommend something very, very simple. No food or fluids 3 hours before bedtime. If you need to take a little bit of water with your pills, that's fine. But again, you want to dose as many pills away from bedtime as possible. Sleep is about a quiescent period. We talked about the gut and the biome. There's a lot of things about the Berenson approach and diet and fasting, but basically you want to have your body's GI system, urologic, your kidneys, they're all in a circadian rhythm and they need a quiet period. So we don't want to be drinking throughout the night or eating throughout the night. And we want to have a period where those body organs also are quieted down. So no food or fluids 3 hours before bedtime. Make sure you're not taking medications that are going to cause sleep disruption at night. Beta blockers are a common offender that are dosed at night in people with insomnia. These should be dosed away from bedtime. All right, so I'm going to move, and SSRIs, I talked about antidepressants, if possible, to move those away from bedtime. This is a slide with it's about principles and physiology, about sleep. And there's two parts to the sleep, natural physiology. When I talk to people, I want to tell people to what we want to do is improve their natural sleep drives. We don't need to use medications, and I use medications very rarely for insomnia, maybe 2 or 3 patients a year. But we can make a lot of progress with these concepts of boosting the natural sleep drive. Okay, there's the circadian rhythm, which is important because it causes you to have a certain kind of clock where you feel awake at certain times and sleep at certain times. So that's sort of about keeping your wake time starting at a certain time. It could be that it starts at 11 in the morning. I'm not judgmental about when you have to get up, but you want it to be consistent. And then you want your bedtime, if you're going to get up at 11, to be more like 2. So you're not in bed too long. That's how you make the clock work. And the homeostatic sleep drive is this principle that the longer you're awake, the more you're going to have a drive to sleep. So this is very intuitive. If you sleep all day, you're not going to be able to fall asleep at night. So you want to be able to regulate or restrict naps and avoid unintentional napping during the day. You can have a little nap, nothing has to be perfect. You can take a little nap if it helps you, but maybe more towards the morning at 11 and just 20 minutes. And then, make sure you don't have these rest periods where you're sort of going half asleep, because then you're not going to sleep at night. This is a very busy slide, but what we do is we try to do things to promote the sleep natural drives. We find out if you're a night owl or a morning lark. If you're a night owl, you might need to go to bed at 2 and wake up at 11. No judgment. But we need to know what your healthy sleep need is. How many hours you need. Some people need 9 hours. Some people are good with 7 hours. And we try to make a bedtime and a wake time that surrounds that and is snugly fits that. Get rid of caffeine, we've talked about. The dozing, we've talked about. Don't lay in bed for long periods if you're trying to consolidate sleep at night. Make sure the other things are treated. We talked about that already. Restless legs, getting exercise. Make sure you don't eat or drink 3 hours before bedtime. Don't have your dog jumping on you at night and watch TV in bed. Okay, so this is the key thing. And it's not sleep hygiene, which is, kind of like a bad word in sleep experts. But, it's the placebo that you compare the good sleep programs to. Sleep hygiene is good. I'm not saying it's wrong, but this is more important. It's the sleep window. And you can see up here, I have 12 midnight, 7 a.m. If you're really trying to get your sleep better, you don't go to bed before midnight and you don't get up after 7 in this case, or this person. And so you can get up, you can stay up till 1 or 2, no problem. And that would be allowed. Or you can get up at 6, that's allowed. So it's not like you have to go to bed at midnight or you have to get up at 7. You just can't extend your sleep and you can't go to bed too early. It's a sleep window. And this snugly consolidates your sleep. It could be that you make a sleep window in somebody who has more dementia of 10 p.m. to 7 a.m. It doesn't have to be this tight, but you always kind of keep them getting up at 7 if they're having trouble with sleep at night. And don't go to bed before 10. That's the idea. I'm just throwing this out there. I know it's not a lot of time to get this concept out there. There are some tips we give people so they're not anxious, like you can't make yourself go to sleep. Just stick with the window and the natural sleep drives do the work for you. It's fine to be in bed in your sleep window and just rest and not be asleep, and you don't have to get out of bed. It has restorative value. Don't look at the clock. And sleep may not be perfect. It doesn't need to be perfect. We make small steps in the right direction. This is the last slide for the main part of this talk. There is something in Lewy body dementia and Parkinson's related dementia that's very, very interesting. The sleep architecture starts to disintegrate a little bit. So when we're awake, it looks a little bit more like we're asleep. And when we're asleep, it looks a little bit more like you can't tell what sleep stage we're in, and it has more awake features. So there can be these cases where you're kind of in between sleep and wake. And you can see people with Lewy body dementia who have these fluctuations, but it's usually later in the course. And there can be these dramatic ones where people are not even aware of what they're doing, but their eyes are open, or they're in sleep and they're making a lot of movements. So this kind of sleep and wake dissolution happens. And we have to do everything we can on the list of all the other stuff that I talked about to try to help keep sleep and wake separated. I have one more slide about medications, just because Namenda is sometimes used in people with dementia, and it seems to have potentially not a bad effect on sleep. In fact, maybe a positive effect. So just so you know, cholinesterase inhibitors, are good in Lewy body dementia very often and can be very, very helpful for many different symptoms. But I wanted to let you know in patients who are having sleep problems, we usually dose these away from bedtime. And donepezil, as great as it is for Lewy body dementia, that's Aricept, also known as, 20% of people can get insomnia from it and nightmares that are vivid. Guess what people have in Lewy body dementia? They have vivid nightmares. So this is not going to help you, but it can help you in other ways. So you dose that Aricept in the morning. But I can't tell you, I've seen a number of patients coming to my sleep clinic. I have a dementia clinic, but also a sleep clinic. In the sleep clinic, and they said, I started having nightmares. And I look back, they were started on Aricept a couple of years ago. We get them off the Aricept or change them to another one or put it in the morning. And those problems with the hallucinations and nightmares actually go away. So that's something just to keep in mind. Melatonin can be used for insomnia treatment as well as REM behavior disorder. And typically the consensus among experts is we don't use very often hypnotics in these patients, including clonazepam, really. If you can treat sleep with the knowledge of some of these things I've talked to you, we don't usually need to use hypnotics or benzodiazepines. Okay, here's the conclusions. I guess I've just listed what we talked about because it's hard to kind of summarize everything I've said, but we talked about REM behavior disorder, that it's common. We want to avoid things that make it worse, support safety, consider a sleep study, reduce things that cause arousals, consider melatonin. We talked about the high frequency and prevalence of sleep apnea and how that can be really important to treat. We talked about hypersomnia, that urge to just be sleepy and not be awake during the day. That could be related to these other things, but also consider the fact that it could be a primary hypersomnia that needs to be treated. We talked about restless leg syndrome and limb movements and how to address those. And we talked about sleep fragmentation and insomnia and trying to boost the natural sleep drives by making a sleep window. In a particular person, you can see how sleep is has a lot of different aspects to it. And Lewy body dementia in particular has a lot of these things that happen that go wrong with sleep in different ways. So there's a lot to intervene on. And most of the time, it's not just one thing that's wrong with sleep. You have to consider all these different things in the sleep study. But the exciting thing is that there's a lot of treatment potential and treatment benefit that you can get from helping with sleep. And that's what I have for today. And I'm very happy to answer questions. Thank you for attending.
Thank you so much. There was a lot of questions, and many of which you actually started to answer as we went on. So that was great. One question that came up early on was, can RBD resolve spontaneously?
That's a great question. And I do see patients where it's more kind of active and florid, and there's much more it's much more problematic and requires a little more aggressive intervention in the first 10 years of people having REM behavior disorder. And there are people where it sort of levels off and becomes less of a problem in later stages of the disease. I don't know the reasons for that. So it can get better. It can. Now, of course, if REM behavior disorder is caused by sleep apnea, it's not really REM behavior disorder, then it's called secondary dream reenactment. It can be completely eliminated, okay? And with some of these interventions where we take away the provoking factors, we take away the serotonin reuptake inhibitor, the Zoloft, or great medication, but we take that away from the nighttime, it actually causes the REM behavior disorder to disappear.
And do you often see RBD with people diagnosed with Alzheimer's disease, or maybe that's more sleep apnea dream reenactment? Does the RBD tend to happen in people that later on are diagnosed with Lewy body dementia?
So, like I said, you can get RBD when you're even young, like a child. So it can be associated with other things besides Lewy body dementia. When you get new onset RBD, you got to rule out sleep apnea. Okay, so that could still be the cause of the problem without it being the sign of a neurodegenerative disease. And like I said, there are these different studies that show different numbers about the likelihood of developing RBD later. If you have problems with autonomic symptoms like constipation, lightheadedness, if there's some executive impairments and maybe a little bit of slowing of and reduced movement of the face that you see that are related to Parkinson's disorders, and then you also have the REM behavior disorder, then it's more likely that you would be going to get REM disorder related to a Lewy body dementia. But it can be from, remember, all the Parkinson's disorders can have that as a cause. Did that answer that question?
I believe it did. Yes.
Okay.
Thank you. So we had some people comment that perhaps their person or themselves, they're on a higher dose of melatonin than what you talked about. And there was just a question of, should they just stop that? Should they wean off of that?
Well, I don't think if they're tolerating it, that's fine. But the one thing I would keep in mind, I should be very careful not to bash other approaches. I'm giving you a particular art of my practice. I do teach a lot of fellows. I'm very up to date on this, but you want to work with your own provider, like Dr. Bateman said, when making changes. I think if somebody's on a high dose of melatonin and they're doing fine, it's fine. But I wanted to alert people to the fact that they need to be checked potentially for sleep apnea. They might want to be not eating chocolate, like my gentleman, if he has his 10 M&Ms that he used to like, or Oreos, then he will have an event. So he's an interesting man. He'll take half a dose of clonazepam if he decides to have chocolate. So making sure those other factors are taken out of the picture might make it so he would be, or she would be able to tolerate a lower dose. And lower dose is always better if you don't need a higher dose. So it is used in literature, absolutely, in studies at doses of 12, for sure. In my experience, I haven't needed those doses, and it seems like those higher doses aren't bringing any extra benefit when we've addressed other factors as well.
I think it's important to note also that you mentioned possible side effects could be headache or diarrhea, and people may not be realizing that that's associated with their melatonin. It may be coming from other things. Oftentimes people with dementia have a harder time expressing a headache as well.
Yeah, and so many times, right, I think it's so important not to discount symptoms in dementia. Like, oh, they have dementia, they're tired, or oh, they have dementia, they can't sleep. So I'm a real advocate for intervention. I have this clinic here called the Aging Brain Clinic, and that's what we try to do, is do intervention, or the idea of it, to not say some of these symptoms are just related to the dementia. Our only role is really to diagnose the dementia. It's to get our hands wet, or what do you say, hands dirty, feet wet, and dive in, because not all people are necessarily optimized, and it sometimes gets discounted. And it's actually a case even in all older people. In geriatrics, it's a big problem that people, and even themselves, might think, well, I'm just old, that's why I can't think as well, or oh, I'm just getting older, that's why I can't sleep as well. Or, and it's true, some of these things do change, but it's worth looking into something and seeing if it can be improved, for sure.
That's great advice. Thank you. Just a couple more questions. Should we wake the person who is in REM sleep and perhaps acting out dreams or nightmares? Should we wake them up?
Well, first of all, you just want to make sure they're safe. So if there's objects around the room, the first thing I would do is take the objects away. And if they're very violent, you don't want to be in that same room. They wake up fairly quickly. It's not usually a need to wake people up. Though, and I don't know that that's the right thing to do, because people might kind of react belligerently before they realize what's going on. So I think it's better not to approach, but you want to make sure things in the room are safe. And if it's a problem that's still going on and you happen to be in that room, you want to get that problem addressed and not be in the room until it's addressed. Okay, so that's kind of a long-winded answer, but I think when somebody's in the throes of this, it's very brief before they wake up, 30 seconds a minute. And I don't think that I would advocate trying to shake somebody, because they might then
Mhm.
react with a fist. And people have had major facial injuries and other things happen. And actually, I've had multiple people who've been sort of choked by their spouse.
So I just wanted to mention to everyone, we have a conference page that we've been sharing out during the entire conference, and we've done some interviews with several gentlemen living with Lewy body dementia, and both of them have talked about sleep disturbance and hallucinations and RBD and what's gone on during the day, what's gone on at night with them. So, and everything that you're telling us sort of in line with what they said. Of course, they're very different. They've experienced different things, as would everyone. But I think it's important to note too all of the other aspects that you talked about, and finding a balance, looking at maybe taking away medications, looking at food and drink. I love the idea of not anything 3 hours before sleep, looking at the activity levels of the person during the day. If they're sleeping all day, of course, they're not going to rest well at night. And I think that's so important. Also to remind people, just from seeing all the different questions that we've had come in, that every single person is different. Every medication affects them differently. So it really is important to talk to a provider. Now, if someone is seeing perhaps their primary care physician, and then they have maybe a neurologist, is this something to speak with the neurologist about, or should they see a specialist? Should they come to your clinic? How can we help them find a person who can treat this a little better?
Yeah, I think it's, I think, my vision, my hope for the world would be that everybody would know everything about everything, right? I do think geriatricians are typically very well equipped to have this right attitude about things, and they can clean things up quite a bit in terms of medications and knowing certain medications that aren't as good in vulnerable populations who are older, and also being advocates. So a geriatrician is a very good person as a primary care person in people who have complicated disorders like this. It just depends on the neurologist and the sleep physician, whether they have, the sleep physicians who are expert in these areas will know a lot about, it depends on the sleep physician, really. Some people are more oriented towards treating sleep apnea, but all of them know something about REM behavior disorder and the restless legs. Many people don't necessarily do as much for insomnia who are physicians, because that kind of, people tend to not know as much about that. But geriatricians are very good at that kind of component. But I think you can inform yourself. Like these slides, for example, will get you started. If people are going to share these slides, I don't know, because you can kind of get a sense of things. I really feel like I said, my patient who saw the talk and then kind of fixed himself and came in. I mean, that's a lot to ask. I was going to just mention, so who do you go to see? You can see a sleep specialist, you can see a geriatrician to get your sleep improved. And then, but just keep in mind some of the cautions that I've kind of tried to share with you today as an expert in the area, that you don't always want to take clonazepam, or you don't always want to take a hypnotic, that there are other approaches to these things. I mean, we have this clinic where we do early assessment of cognitive disorders, where we're also treating sleep. And then there also is a sleep specialties clinic, and I have a nurse practitioner who's very well versed in this area as well here at UNC. But I'm sure there may be other areas as well. But I do think it's just an incredible opportunity to make a big difference in somebody's life. And some of this is not going to get better. I want to mention, we try these things, but Lewy body does have a lot of conditions that affect sleep, like I said, and sometimes we try and it's hard to get everything perfect. So that's not our expectation. I wanted to touch upon the fact that you mentioned visual hallucinations in one of the cases of the patients who shared their story. Visual hallucinations are not uncommonly happening at night. When there's low light conditions, they see something out of the corner of their eyes. And typically, I know that there can be a lot of anxiety that happens in dementia, in Lewy body, but I feel like if you take away medications and improve sleep, some of those psychiatric things can get better, target the treatment of that anxiety. You don't necessarily need, and Dr. Payton probably talked about this, in Lewy body dementia, to always chase those visual hallucinations. Those are visual illusions, essentially. And, people can have those even when they don't have dementia, where you get what we call a hypnopompic or hypnagogic hallucination. And it's sort of like your dream sleep is dysregulated, like we talked about, like you're not paralyzed, but you have a little bit of dreaming that kind of gets into reality when you wake up. It's not getting sharply turned off, in a sense. But so there's the vivid dreaming thing that seems like it's real. And then there's the thing where you wake up and your eyes just don't quite focus and you fill in with some things in your brain because of the visual dysfunction in the Lewy body cases. So as long as it's not causing distress that's too great, you don't need to chase those illusions down. And remember that even normal people can have those. Vivid dreams are promoted by beta blockers and medications. So again, don't be taking your metoprolol at night, or think about which medications might worsen that as well. It's not always only the disease, there are other factors.
Wonderful. Thank you so much for all of this great information. I know it's going to start a lot of conversations in a lot of families who are listening today, so we greatly appreciate it.
Okay.
And thank you for your time and for joining us. We are going to take another break now, and we will come back at 12:30 so everybody can get up and stretch. And thanks again, Dr. Roth. We appreciate you.
Very welcome. I'm glad to have been able to have this opportunity.